Good day and welcome to our series of CPD accredited webinars on the different childhood cancers. My name is Audrey Ludick and I'm the Program Development Manager for CHOC Childhood Cancer Foundation in South Africa. It is CHOC's mission to support children and teens with life-threatening blood disorders and their families, improving early detection and facilitating effective treatment. CHOC offers comprehensive child and family support through psychosocial, emotional, and practical support as we augment the pediatric oncology units in South Africa. Childhood cancer is a rare disease. It is not preventable, but it is curable. And I think the worst words that any parent can hear is that your child has cancer. Now, since 2011, CHOC has been training healthcare professionals, healthcare workers, traditional health practitioners in communities in KwaZulu-Natal, one of the 9 provinces of South Africa. We have done several roadshows that includes training, community interactions, mall drives, radio talks, etc. However, we believe that the doctors and the healthcare professionals in KZN need to be aware not only of the early warning signs of childhood cancer, but also they need to know about the obstacles and the challenges to early diagnosis. Today, we will unpack those challenges. And I believe that these learnings can be applied successfully, not only in KZN, but also in other parts of the country and globally. So since 2011, we reached close to 9,000 healthcare professionals or people working in the Department of Health. That is still not enough. We still have a long way to go. We also worked in all of the 11 districts, and we trained the trainer of trainers or the facilitators in the 11 regional training centers of KwaZulu-Natal. We worked in 69 towns. And in the beginning of November, we spent a week in Richards Bay area and trained over 300 healthcare workers and healthcare professionals. All of these mean nothing if we don't have the cooperation of the doctors and if we don't understand the correct referral pathways. In 2008, and especially since 2017, there has been a significant increase in new diagnosis to the pediatric oncology units in the Inkosi Albert Luthuli Central Hospital and Grace. However, we still have a long way to go to reach the 60% survival rate, and that is the goal of the WHO Global Initiative for Childhood Cancer globally. Now, today it is my privilege to introduce Dr. Beverly Neethling, a very competent lady, but a very modest pediatric hematologist. I asked her to give me a CV. She sent me 5 short sentences. So Dr. Neethling did her undergraduate degree at the University of Stellenbosch and her postgraduate degree at the University of KwaZulu-Natal. She's the head of pediatric hematology oncology since 2012 to 2018, where she established this unit in KZN. And currently, since 2020, she was appointed as the head of the Pediatric Hematology and Oncology Clinic in the Inkosi Albert Luthuli Central Hospital. She has a special interest, and that is late presentation of cancers in pediatrics in KZN, the causes and how to improve early detection. So while Wayne makes Dr. Neethling the host to do a presentation, if you have any questions, please put it in the chat. And at the end of the presentation, we will ask Dr. Neethling to present it to us. The webinar will also be on YouTube afterwards, and I want to ask you to please share this link with all your colleagues and friends so that everybody can hear this message. The doctors will receive 1 CPD point, and if there's any other professionals like therapists or professional nurses who would like a certificate of attendance, you are welcome to contact me and I will send you the certificate. So Beverly, welcome and over to you.
Thank you, Audrey. Okay, just share my screen. So I'm going to speak about and just give an overview of pediatric cancers in KZN, where we were a few years ago and where we are now. So my talk will be about a bit of introduction. I'm going to speak about demographics and referral pathways, our epidemiology in KZN, briefly speak about a collaboration that we did with St. Jude's. I'm going to present some cases just to give you some perspective of what we deal with in this province. A summary of the cases. We're going to speak a bit about early warning signs of cases and of cancer, and then a take-home message.
Beverly, will you just share your screen, please?
Sorry. I am sharing my screen. Is it not showing?
No, it's not showing. Wayne, can you please assist? Let's quickly see.
There's a green button at the bottom there.
Oh, just wave over the bottom, then it will go there.
No.
Now we can't see.
Okay, let me close. Can you see it now?
No, not yet.
Maybe just at the bottom there of your screen, there's a big button in the middle. It's in green saying share screen. You just click on that and then they'll bring up another window where you just click on which item you want to share.
Yeah, this is a Mac, so it's a bit different. Sorry, I did share the screen earlier, so I'm not sure.
Yes.
Let me close it and come back.
Okay.
Sorry.
No
the
problem.
share screen button is
Get
not
that
coming.
right now. These glitches happen.
Is it showing now?
There you go. 100%. Thank you.
Can you see it now?
Yes, 100%. You can continue.
Okay, sorry. So that is my overview. So globally, approximately 400,000 children are diagnosed with cancer. The annual incidence in children aged 0 to 14 years is about 140.6 per million. But this ranges of, there's a threefold difference in regions, and there's variations between regions and ethnic groups. And I think we need to remember this number when I speak further, the 140.6 per million. Large parts of Africa, Asia, and Latin America has missing data due to lack of registries, except for Botswana and South Africa, which actually do provide cancer registries with an estimated regional coverage of 80%, and this is the third highest globally. The annual incidence rate is increasing globally. It is a rare disease in childhood, but it is one of the top 5 causes of deaths in the developed and developing countries. It is a very small number compared to adults with less than 2% of all cancers. Overall survival are more than 90% for some cancers, but for your many rare or your poor prognosis cancers, the survival rate is much lower. more than 80% of childhood cancers in patients in high-income countries, these children survive more than 5 years after their diagnosis, which is not the case for your low to your middle-income countries. There's low rates of pickup in your low to middle-income countries, and this is very often due to underdiagnosis or inadequate registration systems. And it is estimated that about 80% of children diagnosed with cancer are living in low and middle income countries, and that there's a very high mortality rate. But unfortunately, as I said, underdiagnosis or not being registered, no one knows the true numbers. But trends are changing in developing countries due to collaboration with other countries. If I look at, or I talk about the demographics of KZN, KZN is the second most densely populated province in South Africa. In the 2011 census, we had a population of 10.3 million people, and the latest estimates with the mid-2022 census, we are sitting at 11.54 million people. That is 19% of your total population. We also have the third largest population of 15 years and younger children in the country, with the mid-year census 2022 estimated at 3.6 million. So if you look, let me just go to the previous slide. Just to put it into context, if you look at KwaZulu-Natal, we share a border with Mozambique, Swaziland, Mpumalanga, the Free State, Lesotho, and the Eastern Cape. So most often, patients do cross the border from Mozambique, Swaziland, and the Eastern Cape to come and seek care in KZN. And for the past few years, we actually also had quite a few patients seeking care from countries like Zimbabwe and coming to our referral centers. So if you look at your current population estimated at 60.6 million in the country, if you look on the right-hand slide, you'll see that the KwaZulu-Natal has got the third largest population of children of 0 to 14 years, with Limpopo being the highest, the Eastern Cape being the second highest. And of note is that Gauteng actually has the least number of children ages ranged between 0 to 14 years. And also of note, the Western Cape has got a very low percentage of children aged less than 0 to 14 years. And that will become significant later when I speak about it. And as you can see, Gauteng is actually the most densely populated province in the country, with about 16 million people in the province. So if we look at KwaZulu-Natal, KwaZulu-Natal is divided into 3 districts. It is Area 1, and Area 1 have 3 health districts. We've got in total 11 health districts and 3 areas. So Area 1 is your Ugu district, eThekwini, and Ilembe, and this is your most densely populated part of the province. And the referral center for the tertiary referral center for this area is King Edward Hospital, which functions as both a regional and a tertiary hospital. Then the second area is Area 2, and this is Herigwala, Umgungundlovu, and this is where Grace Hospital is situated, Utukela, Umzinyati, Amajuba, and this area is for the western part of the province, and the referral center for this is Grace Hospital. Very vast area, but not as densely populated as Area 1. Then Area 3 is also very rural, as the same as with Area 2. And the health districts there is Zululand, King Sechwayo, and Umakanya Kudi. So if you look at the province, we only have 2 pediatric oncology units in the province. As I said, Grace Hospital is a tertiary hospital, and it is the referral area for Area 2. It only has 13 beds, and you can see the vast area that it has to service. It only has 13 beds, and it's a public hospital. Then Albert Luthuli Hospital is situated in the eThekwini area. We are a 29-bedded unit. We are actually only a 25-bedded unit, but the pediatric surgeons have given us 4 of their beds, and we now have 29 beds, and we function on a public-private partnership, and we are the central hospital for the province. That means that everything is referred ultimately to Albert Luthuli if it's a high-risk case, etc. So if we want to talk a bit about the history of the two centers, and these are non-private centers. The Albert Luthuli unit was established in 2003. Historically, it was at King Edward Hospital, but in 2003, they moved across to Albert Luthuli Hospital. And at that stage, it only managed hematology patients. That meant hematological malignancies and your benign hematology. At that stage, there was only 1 hematologist and 1 fellow. And in 2016, there was a big oncology crisis in the province, and the hematologists were forced to take over managing the solid tumor patients in the province. And these patients historically was managed either by adult oncology or by pediatric surgery. So it was a very, very fragmented service in KZN. And we never had pediatric oncologists in the province. In mid-2021, our unit acquired 2 qualified pediatric oncologists. Gray's Hospital was established by a pediatric hematologist in 2012. In 2013, a pediatric oncologist joined the hematologist, but he subsequently left in 2016. And then the hematologist went to Albert Luthuli as there was a crisis at Albert Luthuli. And Gray's was then only managed by 1 medical officer. But with the support of Albert Luthuli via WhatsApp, video conferences, bi-weekly visits, but all the high-risk cases were moved to Albert Luthuli. The low-risk patients were managed at Gray's. And since mid-2021, also a qualified pediatric oncologist joined Gray's Hospital. So in the province at the moment, in the public sector, we have 3 pediatric oncologists. And as you can see, we only have 29 plus 13 beds in the province. So that is not many beds that we have to deal with the population of the province. And even in terms of oncologists and hematologists, not enough to deal with the patient load in the province. In terms of the private referral centers, there are 2 hospitals. 1 hematologist at Parklands Hospital, but this is also based in Area 1, and at eThekwini Hospital, 2 hematologists also based in Area 1. So once again, no service in Area 2 or in Area 3 from a private perspective. So all the private patients are being down referred to Area 1 to these doctors. And this is the service that we provide. Either hematology, your benign hematology, or your malignant hematology, which includes your leukemias, your lymphomas, and your other oncological hematological conditions. And then obviously your solid tumors, which includes your brain tumors and your non-CNS tumors. So a bit in terms of the epidemiology of KZN. This is an article that was published in 2015 in the SAMJ by Prof. Stefan et al. And they looked at the incidence of childhood cancer in South Africa, and they looked at it over a period from 1987 to 2007. And they looked at the annual incidence rate per 1 million children from the age of 0 to 14 years. So if you look at that stage, KwaZulu-Natal actually had the most children aged between, if you look on your left-hand column, the most children aged between the age of 0 to 14 years, about 3 million children in total. Once again, the Western Cape of note only had about 1 million children in the province during that time period. But if you look at your annual incidence rate, just remember, KZN, highest population, much more children than the Western Cape, but our annual incidence rate was only 39 per million children, whereas the Western Cape had 88.4 per million children, and Gauteng had 81 per million children. So the question is, what is happening in our province, where is the problem, why is our incidence rate so low? And this was between 1987 and 2007. Come now to most recent statistics. In 2018, this is statistics from the National Cancer Registry. A total of 975 patients were diagnosed with cancer in aged 0 to 14 years. And as you can see, as trends are locally and internationally, we follow trends internationally. Your leukemias, your lymphomas are your most common malignancies very often, followed by your CNS tumors, your renal and your eye tumors. So the numbers are very similar to what you see internationally. So if you look at your age standardized incidence rate, and this was per 1 million children, the overall ASR was 59.8 per million for the whole country. And if you compare it to the year 2000 to 2006, when it was 45.7 per million, the incidence is better, but still not where we want it to be. Remember, globally, it's 140.6 per million children. And our local society registry, from the period 1987 to 2007, the incidence rate was 45.2 per million children. This was our local registry in 2021. Once again, very similar. Your leukemias are the most commonly diagnosed cancer. Here it is followed by your brain tumors. If you combine your lymphomas, it comes to about 9.7%. So it is still one of the most common cancers, followed by your nephroblastomas and your retinoblastomas. So what is the significance of this? So of those 815 patients that were registered, 19.9% was from KwaZulu-Natal, 20.5% was from Gauteng, and 17.8% was from the Western Cape. And remember, if you look on your right-hand slide, I said before, KwaZulu-Natal, in terms of children 0 to 14 years, third highest in the country, about 3.6 million children. Western Cape, second last in the country, much less than KwaZulu-Natal. So I just did a very crude annual age standardized rate for the period 2021. I know it's very crude because I used census data from 2022. But if you look at your ASR for KZN, it's sitting at 45 per million children. Gauteng, 44 per million children. The Western Cape still sitting very high, 83 per million children. So about 15 years down the line, still, where are our children in KZN? Are they not being diagnosed? Are they misdiagnosed? Where is the problem? So this is just a breakdown of our patients. I just looked at data for the past 5 years from 2017 to 2021, and we diagnosed 731 patients in the province. This is exclusively our private patient, our non-private patients. And our highest rate of percentage of patients was in 2018, where we diagnosed 175 patients. And this has dropped quite significantly in 2020 and 2021, but I suspect that COVID that played a role for us to have seen less patients during this period. In terms of the breakdown of the types of cancers that we're seeing, once again, very similar to our local data and international data, but we tend to see more nephroblastoma patients in this province. 124 of our patients were nephroblastoma patients, but I must say many of these patients are actually patients that crossed the border, either from Swaziland or from Mozambique or from Zimbabwe. So many of these patients were not local South African patients. In terms of our acute leukemia patients, this is expected. Your lymphoblastic leukemias are the most common, followed by your myeloid leukemias, and then thirdly, your promyelocytic leukemias. So we did a collaboration with St. Jude's, but all the pediatric oncology units did a collaboration with St. Jude's. And this was essentially a facility evaluation. So they looked at many variables and outcomes. They looked at what our finances and our resources were per PUI. They looked at our infrastructure. They looked at our personnel. They looked at our diagnostics, our therapeutics. But what I want to focus on is our patient outcomes. And if you look at the radar graphs for Albert Lutuli versus Grace, it looks very, very similar. So what are these graphs telling us? It's telling us that we have the finances and the resources. I don't know how true that it is. On paper, we may have the finances and the resources, but that is not really true. But that's not what I want to focus on. What I want to focus on is our patient outcomes, and our patient outcomes are not good. The module outcomes for both our facilities showed that our patient outcomes were sitting at 54%. And that nationally, it wasn't so far off from the national tallies, but it is not good generally. So what was the recommendations from this radar graph that we from St. Jude's? So I'm not going to focus on everything. They spoke about we need to increase our prospective data collection, upfront palliative care services, which we do have. We've got an excellent palliative care service in the province, Umduduzi. We should reduce our early deaths by tracking and reducing time to antibiotics. We could work on that, but I don't think that's a big problem for us in KwaZulu-Natal. But what I do want to focus on is increase the percentage of patients initiating treatment with curative intent. So where are things going wrong for us? Where are things going wrong for us? Why can we not initiate treatment on all our patients with curative intent? So I'm just going to do a few case presentations, and I'm going to give you a bit of perspective of what we see and what we deal with on a daily basis. And these are not exceptions. This is what we deal with on a daily basis. So the first patient was a 10-year-old female, and note the dates. She presented with an intermittent abdominal pain to her district hospital in November 2021, and she was managed with analgesia. 2 subsequent visits to her local clinic, she had right flank pain, and she vomited after her feeds, once again sent home. She was subsequently referred back to the same district hospital on her second visit to the local clinic. At this stage, she had loss of appetite, loss of weight. She was treated symptomatically once again, and she was discharged. In March 2022, she presented with abdominal distension and vomiting, but she now went to a different district hospital. So mom was going from one healthcare facility to the next. At this district hospital, they did an ultrasound, which showed query in an enlarged left kidney, and she was referred to her regional hospital with a suspected left renal mass. From there, she was referred to Albert Lutuli, the pediatric surgeons, in April of 2022, and she was referred for a biopsy of this mass. And following the CT scan at Albert Lutuli, the mass was biopsied, which showed a small blue round cell tumor in May, and she was subsequently referred to us on the 6th of May. When we saw her, she had a huge mass in her abdomen. She was extremely cachectic. Her mass was 25 by 31 centimeters in her left lower quadrant, extending to the right. And on the 18th of May, there was a problem with her diagnostics, and they had to rebiopsy her. She was eventually diagnosed with a Ewing or a Pinhet sarcoma. This is her CT scan. And as you can see, there's a large heterogeneous soft tissue mass measuring about 18 by 18 by 21 centimeters. There's distortion of the pelvic coliceal system with hydronephrosis and hydroureter. The mass was displacing the aorta, the inferior vena cava, and the bowel wall to the right. She had multiple intra-abdominal lymph nodes. She had the left pleural effusion with multiple long nodules, and the origin of the mass at this stage was not clear. So she was already a stage 4 patient. This was her PET scan, and I'm not sure if it's showing very well, but with the arrows, you can see on the right-hand side, she's got lung nodules there in her lung. That's that red, the metabolically active lesions. She's got active lesions in her liver. She's got on the left-hand picture, she's got a lesion in her right humerus and her left ischium. So this child had extensive disease. So of course, she was a stage 4 Ewing sarcoma. Sad case, 5-year survival rate for localized Ewing sarcoma is about 70%. The 5-year survival for metastatic disease drops right down to 15 to 30%. And this child was misdiagnosed. This mom sought help. She went to different healthcare facilities and the child got diagnosed 5 months later. So earlier diagnosis would have made a huge difference in this child. Second case, this was an 11-month-old female. She presented in October 2019 with left thigh pain, but this was now since March 2019. The swelling was noted by the mom in August 2019. And in October, she sought help because there was now left thigh swelling. It was becoming worse. She had loss of weight, loss of appetite. She had night sweats. She was in severe pain and she was not able to mobilize. This is an MRI of her left femur. And if you can see on the right-hand side, she's got an expansion and abnormal signal intensity of her left femur diaphysis, starting 6 centimeters from her knee joint, extending 23 centimeters superiorly and 7 centimeters from the greater trochanter. And she had a pathological fracture in her distal third of her left femur. You can see the fracture there. So her histology showed that she had osteosarcoma. We needed further biopsy for subtyping. Her CT, chest, and abdomen showed no distant metastases. So at this stage, this child was a non-stage 4 disease. But her bone scan did show some skip lesions. She was commenced on neoadjuvant chemotherapy. The mom was counseled about the timing to restaging and the high probability and possibility that she might need an amputation of that leg. And the mom was agreeable for us to proceed with the treatment. And she showed an excellent response to the neoadjuvant chemotherapy. There she is, post-neoadjuvant chemotherapy. She's standing, she's without pain, she's able to mobilize, and she's got a huge smile on her face. And that is our social worker and one of our ex-team members. So pre-surgery, we did another MRI. So despite the good clinical response that she showed, when we did the MRI, it actually showed that this child now had progression of disease. There was an increase in the size of the tumor in the first place, and also the skip lesions. If you see the red arrows have now increased. There's more skip lesions and they have increased in size. So although clinically this child showed a good response, radiologically, she had progression of disease. So we needed to proceed with amputation because the chemotherapy was not effective. So in February 2022, the mom was counseled that limb-sparing surgery was not an option, and amputation at this stage was the only option. The mom at this stage felt that there was never a discussion about the amputation, but only removal of the tumor. And this is often what we get from the parents. They will regress and they will say they were never counseled, although the team counsels them at every step of the disease. We've got a very good palliative care team. We've got a social worker on site. The doctors do ongoing counseling in the unit. The mom requested to go and discuss it with the family. At this stage, we agreed, but we said the child need to stay in the ward, and she left the ward. Subsequent to that, we attempted to contact this mom on numerous occasions, and she was just not contactable. The child, during this course of time, turned 12 already. She knew what her diagnosis was, and she was informed by the doctors, or it was discussed with her that there was a need for an amputation. The child refused the amputation and said that she will only do what her mom wishes for her to do. Eventually, we got hold of the grandfather, and he arrived a few days later, and he explained that he's actually the primary caregiver of the child, that the mom is not really interested, that she has a new boyfriend, that the paternal dad has committed suicide, and the mom has requested for him to come and discuss the case with us. He requested for the child to be discharged and give the child the family time to discuss the matter, and he promised that he will bring this child back to the hospital. They never returned to the hospital. The palliative care team was very involved in this case at this stage, and they contacted this family, and this family refused to return to hospital. The family decided against the amputation telephonically. They wanted to perform cultural rituals, and they had certain beliefs that they believed in, and they asked us to give them time to first perform their rituals, and we generally do work with the family. We do not say no. If they ask for some time, we will give them generally 3 days to a week to do what they need to do, but we always advise them to not do anything where you have to make any scarification marks, that the child has to drink or ingest anything. And then they took this child to a Sangoma in deep rural part of KZN. And this child was now staying with the Sangoma. The exact location to us was unknown. And numerous attempts was made by the doctors, the social workers, and the palliative care team for this child to be returned to hospital. Eventually, she returned after 4 months, obviously now with progression of disease. As I said, she was 12 years old. Amputation was discussed again. She came with her mother, and she was not agreeable to the amputation. She still believed that the Sangoma could cure her, but at that stage, she was already writing letters about death. So this was a case of late presentation and also very, very strong cultural beliefs. And this was the progression of the disease. This was the pictures that was being sent to the palliative care team. Eventually, she came back to the hospital, but by that time it was too late to do anything for this child besides offer her palliative radiotherapy to relieve the pain. Case 3 is a 4-year-old male, and this child was originally from Zimbabwe. And this mom noticed a yellowish lesion in the child's right eye in 2016. The doctors diagnosed this child with a right endophthalmitis. An intravitreal tap was done, and injection of antibiotics was done. In January, I think this mom subsequently went back to Zimbabwe. In January 2018, she returned, and now there was a history of recent trauma to the right eye. And she said the child was hit with a stick 2 weeks ago, and that is now why she's seeking medical help. And the child was, or she was complaining of right ocular swelling since the trauma. And this is the child. So he presented with marked proptosis, drying up the cornea. There was absolutely no vision in that right eye. And this child was diagnosed with retinoblastoma. We did a CT scan. There was no intracranial extension. The CSF unfortunately showed that there was malignant cells. So this child had extraocular disease. This child thus had CNS disease. The bone marrow showed no infiltrate. So this child was a stage 4. And the prognosis for 5-year survival with early detection in retinoblastoma is excellent, 96% overall survival. With metastatic disease, it's extremely poor. So this child now was a child who presented initially with a lesion on the eye and now has progressed to a stage 4 disease over a 2-year period. So this was a case of misdiagnosis, because when the child presented initially with that yellow lesion in the eye, no one thought, is this not a possible retinoblastoma? The child was treated as if he had an infection. The fourth case is a patient, a 12-year-old female, and this child came from Swaziland, and she presented with a 6-month history of a progressively enlarging neck mass. And the biopsy of the neck mass done at the district hospital confirmed a diagnosis of a Ewing sarcoma. So by the time she arrived to us, she already had the diagnosis of a Ewing sarcoma, and this is the 12-year-old girl. She could not straighten her neck at all. She had a severe kyphoscoliosis and this massive neck mass. Clinically, she had neurofibromatosis type 1. She was already quadriplegic. She had a severe kyphoscoliosis, and we suspected that she had a giant plexiform neurofibroma, which transformed into a Ewing sarcoma. And that was the MRI of her neck. And as you can see, this mass is infiltrating the vertebrae. It is displacing vital structures. There's severe canal stenosis. There's a compressive myelopathy, and she's got a severe acute angle kyphoscoliosis. And that's the CT scan, once again showing the neck mass extending into the spinal cord and displacing the spinal cord. And also she had multiple pulmonary metastases. That's one nodule there in the lung. So once again, stage 4 disease, poor prognosis, overall survival, 15 to 30%. The bone marrow didn't have any obvious involvement. As I said, the staging CT, we had a strong suspicion that it was lung metastases. However, it could have been neurofibromas. The lesion showed a very poor response to chemotherapy, and the parents were subsequently counseled on the prognosis and the complexity of the surgery, and based on that, they decided against the surgery. They took her back to Swaziland, and they promised to bring her back for follow-ups so that the palliative care team could still be involved, but they never returned. So this was a case of late presentation, no care, access to care, and lack of expertise in her own country. So she came all the way from Swaziland seeking help, and she had to travel a very long distance to get access to care due to the low density of physicians in that area. And this is the last case I'm going to present. And this is a child who presented with an angiosarcoma. She was a 5-year-old little girl and showed a poor response to chemotherapy. She didn't have any local or distant metastases, so this was purely localized disease. And limb salvage was not an option, as the mass had showed extensive local invasion of vital structures. So an above new amputation would have been curative because there was no distant metastases. The parents were counseled extensively on the amputation, but they were not agreeable to any intervention, as they first wanted to take this child to a prophet in Johannesburg, as they believed that this prophet could cure this child. Once again, extensive counseling, palliative care team was involved, social worker was involved. After a week of back and forth, we eventually said, okay, you can take this child to this prophet, but we give you 3 to 5 days to bring the child back. They promised to return the child the following week, and they never returned because they believed that the prophet will cure the child. We did not know where they were at that stage. Were they back in Johannesburg, or were they now in KZN? And let me just say, in KZN, it is very difficult to find patients, because if they live in their villages or they live in locations, very often the houses do not have addresses attached to them. So the address that you will get is near this school or near this area, but you will not get an actual physical address from the parents. So once again, here, refusal to an amputation based on very strong religious belief and misperception or misconception about cancer. So a summary of the cases: 70 to 80% of our patients in this province presents with advanced stage disease cancer. It is either because of late diagnosis, misdiagnosis, abandonment of treatment, and then eventually coming back when it's too late, or underdiagnosis. As we have seen, if you look at our AIDS standardized incidence rate, we are not diagnosing the patients as we should. Our diagnosis rate is very low. And with this advanced stage disease presentation, all of this leads to the fact that our outcomes in this province is very low. So what is the possible problems in this province? This province is very deeply steeped in tradition. Cultural beliefs is a big thing in this province. For example, and I've heard about this a few months ago, if you pass away and you are being handed over to your ancestors and you are not whole, so for example, if a limb has been removed or an eye has been removed, the ancestors will not accept you in the afterlife. And that is why so many parents, once you speak about amputation, once you speak about enucleation of an eye, they stop you just there and they refuse that. They will agree to organ removal because you can't see it with your eye. But once it is disfiguring surgery, that is where we have big problems with the families. And this is because they believe that, as I said, if you do not present yourself whole to your ancestors, you will never be accepted in the afterlife. Hierarchy is a very big thing in this province. So there's always a matriarch or a patriarch who makes the final decision. And no matter what the child says, if the grandfather or the grandmother is the matriarch or the patriarch, the mother will listen to that person. If the aunt is the matriarch, she will be listened to. So what that person say, that stays, irrespective of what the mother feels or what the father feels or the child feels. And the mother and the child and the father will follow what the matriarch says. Then there's this cultural perception of the disease. Very often, they will not accept the diagnosis of cancer. They would say the child has been poisoned either by a neighbor, by someone that's jealous, by a girlfriend of the father, etc. But they would not believe that the child has cancer. Even if you show them the results, you print out the results, you show them the child has got a leukemia, they will not believe those results. And as I've showed you before, also religious beliefs very strong in this province. They believe that the prophets will heal them. And of course, big problem is the socio-economic circumstances in the province, a lack of education, lack of access to awareness, the low density of physicians. I showed you how few of us there are in the province. Most of our patients come from rural areas, long distances for them to travel to healthcare facilities, and lack of awareness of early warning signs of cancer. And that is not just, and that is across the board, lack of early warning signs of cancer. So this is the early warning signs of cancer. I think we're going to run out of time, but this is the Siluan signs. And we all know that it was because of a monk. We know the history behind it. I'm not going to go into detail, but S stands for seek help. The E is for the eye. If there's a white spot in the eye, remember that child who presented up front with a white spot in the eye. If a child has a lump anywhere on the body, unexplained fever, loss of weight, pallor, fatigue, easy bruising, bleeding of the gums, swelling of the gums, a child that suddenly stops walking, who was running around before, a child who complains about bone pain, a child shows neurological regression. Those are the early warning signs of cancer. And this is probably what that one child with a retinoblastoma presented with up front in 2016. Mom said the child had a yellow spot on the eye. The child was misdiagnosed. This is a child who presented with lumps, but he was diagnosed early. He did not have any, he only had localized disease, and look at the excellent response that he had to our treatment. So early diagnosis is key and vital. And if I mean early diagnosis, it means you need tissue diagnosis. Tissue diagnosis is very, very important. So if you are concerned that the patient has a malignancy, do not just go and start TB treatment. Very often people start TB treatment, they start the patients on steroids, and the steroids mask a malignancy. If the patient has a lump, biopsy that lump. Don't just start treatment without knowing what you are treating. This is a child with easy bruising who was diagnosed with leukemia. This is a child who presented with acute myeloid leukemia, and they typically present with gum hypertrophy. And this is a child, this is an extreme case, but this child had multiple fractures all over his body. And he obviously had severe body pain, and he stopped walking. And that was a warning sign for the mother that something is wrong in this child. And this child was diagnosed with an acute leukemia. So what is our take-home message? We need to actively have awareness campaigns. I think I've been speaking to CHOC since prior to COVID, and specifically to Aggie, our regional manager, about we need to have awareness campaigns, and CHOC is actively doing that via social media. The problem with social media is most of our patients don't have access to social media. So perhaps via the radio, but we actively have to go into the villages. We have to educate our community-based workers, the teachers, the schools. We have to go into the primary healthcare clinics. We have to speak to our healthcare providers in the district hospitals and the regional hospitals. And education of early warning signs is key. And it needs to start with our medical students, our nursing students, our allied staff, and even with our medical staff, and very important, in the community. And we need to include our traditional healers and our chiefs of our villages. Because if we get the buy-in from our traditional healers, if we get the buy-in from our chiefs, I think patients will present to us earlier and our outcomes will improve. And obviously, when the patients get to us as the end physician, it's a multidisciplinary approach. We have doctors, nurses, we've got a social worker. We now have a psychologist. After many years, for the first time, we can consult a psychologist. We've got an excellent palliative care team. And it is important that the child needs to be counseled, the family needs to be counseled, not just the parents. It is like you need to counsel the whole village. If you want a response, you need to look into the family circumstances. Is there an underlying problem? The socioeconomic background is very important. The spiritual beliefs, the cultural perception of the disease is very important. And that is the end of my talk. And just once again, early warning signs of cancer, we all need to be aware of it. And I think it is time for change. We need to improve our detection rate, our diagnosis rate, and patients need to present to us earlier for our outcomes to improve. Thank you.
Wow. Wow, Beverly, I've got goosebumps really. That was amazing. You gave us so much insight into the challenges of KZN. And I believe that we still have a lot of work to do there. If I think about the pain that the children must experience when they are in late stage of the disease, then it's against the human right of those children. And together we must stand and really do and ensure that we destigmatize the myths and beliefs around childhood cancer, and that we make people aware of the early warning signs of childhood cancer. And I really want to invite everybody on the webinar today to invite CHOC to come and do training, because the way that we do the training is very simple. We do it through adult facilitation. We impart the knowledge through gamification. And so when the people leave our training, they really know the early warning signs of childhood cancer. And that's all we want them to know, is to know the early warning signs of childhood cancer, and then where to refer possible cases to, and how to refer possible cases to. So we also work very closely with the National Department of Health and the African traditional practices. And we hope that next year we will train a lot of traditional health practitioners through the Department of Health. I just want to see, I see there is a question in the chat. No, there is not a question. I can't see the question. I see this on the screen, there's one question, but unfortunately, I think it's maybe where I ask everybody to put their questions in the chat. There's a second one. Wayne, why can't I see the questions? Let me just have a look here. Oh, somebody said, Dr. Neethling, thank you, that was great. Have you engaged with traditional healer and community leaders? What has the response been to your invitation to work together? I don't know, Beverly, would you like to answer that question?
Audrey, I think CHOC can probably answer that question better, but I can just speak from experience when I worked in Gray's Hospital, was when we engaged with the traditional healers, and we actually took one of our nursing sisters into the rural areas, and she went to go and do education together with CHOC, and that made a big difference. The traditional healers are actually willing to engage. It's not they are not willing to engage, it's just for us to break those barriers and engage. But I know that CHOC did a big drive in area 2 when I was there, and they are currently doing their drive in area 3, where all the rural patients are, to engage with the traditional healers. And some of our mothers are actually traditional healers. We've had at least about 3 patients that have come through the unit where the parents were traditional healers, and you get a good insight into how they think and how they do things. And you have to work with them. You cannot work against them. Otherwise, you will never see the child again.
Absolutely. We actually have CHOC community trainers that are traditional healers that go into the community and train. The most important fact that we need to remember is that the nurses at primary health care level and your traditional health practitioners are the influencers in the community. But the traditional leaders, the chiefs, they are the decision makers. And I think if we can get to them to open the doors for us, then the traditional health practitioners will trust in us much more. So we need to come through 2 lines to the traditional health practitioners. That is through the chiefs in the communities and through the Department of Traditional Health of African Traditional Practices, which is part of the National Department of Health. So we are working with them, and we've been working with them very successfully for many years. They are open to our knowledge that we give them, because it also helps them to make the right decisions. Let me just see if there's any more questions. Yeah, thank you. That was very interesting and a very good presentation. And there's the anonymous attendees said there's a lot of work for us that lie ahead. So if there's no further questions, I just want to thank everybody for attending. Our next and our last webinar this year will be on the 30th of November, and that will be done by Prof. Alan Davidson, and that will be on brain tumors. Please go on our website and please register on the events page. You are most welcome. It's a free webinar, and please share this information with as many people as possible. Thanks for joining us. Thank you so much, Beverly. You've been absolutely amazing. Thank you, Aggie, for the work that, thank you. Thank you, Aggie, for the great work that you do as the regional manager in KZN. And thank you to everybody who attended. Our technical team, you know, we love you lots and we appreciate the work that you do for us. Please go out there and make a difference. And we hope to see you at our next webinar on the 30th of November. Thank you very much and God bless.
Thank you. Bye.
Bye-bye, Beverly. Thank you.